Howdy, y'all. Before we get started, I want to send out a really big thank you to my friends Ginger, Locke, and Samuel Martin. Ginger did an amazing job on the vocals for our intro and outro. You may recognize her voice from the Medic Mindset podcast. If you don't, shame on you. Go listen to it right now. Samuel Martin is a friend who is an amazing musician. He is also an outstanding editor. He did the music and the editing for the intro and outro. Speaking of which, let's get to it now.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to episode 52 of the EMS Lighthouse Project podcast. If you remember from our last episode where Mike and I were hanging out by the pool while he was down here in Central Texas for F1, we talked about a change in the lineup of the podcast. Mike and I have been doing this podcast together, but because of scheduling difficulties and our desire to crank out episodes when we want to, we're splitting it up, and I'm going to be doing the hosting on my own. And you may have noticed that we had Ginger do a little bit of a redo on the intro. Well, as an example of what I meant by cranking out a paper as soon as the urge hits us, as soon as a paper hits, I want to tell you what I was doing this morning. It's a Saturday morning. It's December 18th. I was sitting there sipping my coffee, playing some stupid game on my iPad. I got my dog, my wife next to me. We're enjoying a nice, early, relaxed morning, and I get a text from my friend, Dr. Heidi Abraham. Heidi says, "Hey, Jeff, have you seen this paper?" Well, I had not seen the paper. I took a look at it and said, oh my God, I got to crank out an episode. So here we are a couple of hours later, and we're talking about this paper. So the topic today is Bougie use versus a malleable stylet in endotracheal intubation using standard geometry VL intubations, or standard geometry MAC DL intubation, because, well, there's basically only standard geometry. The citation for this paper, it's hot off the presses. It is Driver et al., and the title of the paper is Effect of Use of a Bougie versus Endotracheal Tube Stylet on Successful Intubation on the First Attempt Among Critically Ill Patients Undergoing Tracheal Intubation, a randomized control trial. Again, this was published in JAMA, and it went up online December 8th on their website. That is a really long title. Basically, if you work out some acronyms, the acronym for this trial is the Bougie trial, which is just an amazing name. Now, I want to start with a caveat that nothing I am about to say, nothing in this episode has anything to do with intubating cardiac arrest patients or intubating patients with a hyperacute angled blade, a hyperacute geometry blade. And to give people an idea, video laryngoscopy, I think most of us know now, lots of different flavors of video laryngoscopy, basically two big types, and one of those types can be used in two different fashions. So quick note on terms. Video laryngoscopy can have two types of blade geometry, either a hyperacute or standard geometry blades. So the hyperacute, those are things like the CMAC D blade, the McGrath X blade, the King Vision, any blade. Let's see, what else? The GlideScope, the classic GlideScope. AirTrack also has these. Those are the hyperacute angle blades, and because Bougies don't work real well with those, we're not even going to talk about them. All right, so exclude those. Next up is the standard geometry blades, and those are basically the MAC blades. Now, you can use standard geometry VL either in a direct or an indirect fashion. And what I mean by that is a direct fashion is visualization. You are directly visualizing the chords without using the screen. You can also use it in an indirect fashion in which you're indirectly visualizing the chords and the structures by looking at the screen. So with those terminology out of the way, let's jump into this paper. So this was a randomized trial, standard geometry blades with Bougie versus endotracheal Stylet. So basically the malleable Stylet, not the rigid T-piece glide right Stylet that we use with the hyperacute angle blades. Old-fashioned Stylet. Now, we do know a couple of things from prior work on this, including by Driver himself. There have been a couple of small observational trials and even one small randomized control trial. And what we know from those trials is that first pass success has been higher with the use of the Bougie. And I would even say that it has become standard of practice, maybe not standard of care. I don't want to use that term, but maybe standard practice to use a Bougie on all attempts. And in large part, that was because of a paper by Driver. So that paper was a single center paper, Hennepin County, large emergency department, academic emergency department. They really focused in on good intubation technique, using a Bougie on all attempts. And it was a single center observational trial of consecutive intubations. And the way they determined what first pass success was is by using the cameras that were mounted up in the resuscitation room. So independent observation, pretty good methods. So one caveat about this study is they really were using EM residents who had extensive experience with the Bougie. They used only the CMAC with the standard geometry blade or DL, and they excluded hyperacute angle blades from this. And the bottom line is they found 95% first pass success with a Bougie compared to 86% first pass success without a Bougie. So I think that really is the study that convinced me and convinced a lot of people that we should go with a Bougie on first attempt and every attempt. A little history, just because I think this is fascinating about the use of the Bougie. Bougie is not a new thing, even though I didn't learn about it in paramedic school back in the late 80s. As a matter of fact, I didn't learn about it until maybe the late 90s or maybe even the early 2000s. It just wasn't something I was aware of, but it was actually first described back in 1943. So 1943, it turns out, was a pretty big year for laryngoscopy. There was this guy named Dr. Robert Miller, and he practiced in San Antonio, and he wrote some papers in 1943 describing the use of what he called a straight blade, and that has now become the Miller blade. Also in 1943, Sir Dr. Robert McIntosh, or Dr. Sir, very confused on this, he wrote this paper, and he described the importance not of using a curved blade that would later become named after him, but of using any blade to go into the vallecula and indirectly lift the laryngoscope. And the reason he said that was so important is to make more room for tube passage. So I find it fascinating that the Macintosh blade, which has now sort of become standard geometry blade and standard for DL, was named after a guy who didn't actually talk that much about it, or at least in his original papers. Also in that year, he described the use of, a Bougie. So it's not exactly new technology. Let's talk about this current paper. This was a multi-center randomized control trial of 11 U.S. hospitals, including 7 academic emergency departments and 8 academic ICUs. Now, what do I mean by academic? 1, I mean they're at big urban hospitals. And 2, I mean almost everything is done by either residents in the emergency department, almost always emergency medicine residents, and residents and fellows in the ICU. And most of those residents, even though they will certainly have some EM residents up there, you will also have internal medicine residents, and you'll have pulmonary critical care fellows who are working up there. Now, in general, Emergency medicine residents have a lot more experience with intubation than internal medicine residents. However, when you get to the pulmonary critical care fellows, they have a fair amount, quite a bit of experience with intubation, but you're dealing with slightly different groups there. So we're dealing with multi-center randomized control trial in the ICU and in the emergency department. This included all adult patients who were going to undergo intubation using sedation and either direct laryngoscopy or a standard geometry VL device. Of that group, to give you an idea, these were almost exclusively RSIs. 97% used sedation and a neuromuscular blocker. Why not 100%? Well, it turns out there were about 2.5% to 3% who appear to have been intubated for cardiac arrest. And it's a little hard to tease out whether they were intubated because of cardiac arrest or they went into cardiac arrest because of the intubation. I can't quite tell. Now, they excluded the normal patients. They excluded pediatrics. They excluded pregnant women. They excluded prisoners. And they excluded anybody that you used a hyperacute angled blade on. So why are they excluding the hyperacute angled blade? Again, because, as we mentioned before, Bougies typically don't help with those hyperacute angle blades. You need a rigid stylet that'll look around the corner in the same way the hyperacute angle blade does. So these patients were randomized on a one-to-one basis. One patient randomized to Bougie use on the first attempt, one patient randomized to a malleable stylet on the first attempt. Everything else was at the discretion of the treating physicians. So this was a pragmatic trial, and it was really focused just on Bougie versus no Bougie use. Now, they did do some additional training across all sites. They had a standardized video that taught about the technique for Bougie use, plus how to use the malleable stylet. With the Bougie, they did it in pretty much the traditional approach. Visualize, see the epiglottis, pass the Bougie, have an assistant pass the ET tube over the Bougie, then pass the tube over the Bougie through the cords while the blade is still in the mouth to keep the tongue out of the way. And the malleable stylet was bent anywhere between 22 to 35 degrees in a hockey stick angle. So that was the training in the video, and then they reinforced that with in-person training before the onset of the study. Now, their primary outcome in the study was first pass success. The traditional approach and definition of first pass success is that the endotracheal tube is successfully placed in the trachea between the time the blade first passes the alveolar ridge, or where the teeth should be, and when it comes out. So blade goes in, blade comes out, there's a tube in place, that's a first pass success. This study, however, their primary outcome was blade insertion and either one pass with the Bougie or one pass with the ET tube. That was a first pass success. So as an example, what most of us would consider a first pass success, blade goes in, Bougie goes in, misses the cords just a little bit, backs up just a hair, never comes out of the mouth, readjusts, goes in, that would not be considered a first pass success in this trial. So the definition is a little more strict than the classic definition. All right, so how did they determine that? Well, they used trained third-party observers. So in other words, they had research assistants in the ICU, in the ED, and they would directly visualize what the operator was doing, and they would make notations. So they looked for whether it was a first pass success, how many attempts it took, both with blade insertion and passing a Bougie or the tube. And then they would also look at how long it took, and they would look for the secondary outcome, which is severe hypoxemia. So they wanted to see, was there a peri-intubation SpO2 less than 80%? 80% was their cutoff in the peri-intubation period, and they defined that as the time from induction with medications to 2 minutes after successful endotracheal placement. And then they looked at some other things that really weren't the main part of the study, but if you're collecting this data, you may as well get in some more additional information. None of that is particularly important in this trial. The statistical analysis on this was really pretty straightforward. They just looked at proportions, and to compare proportions, first pass success versus first pass success, they used a chi-square test. Most importantly, they used it using R. So I'm a big R fan. Strong work, guys. They did some other more complex statistical analysis, but it was all as part of a sensitivity analysis. So they would do some things to say, well, would these results have been different if we had used another statistical approach? And they predefined a bunch of different approaches to this. They looked at an adjusted analysis, adjusting for things like difficult airway, BMI, age, sex, that type of thing. They also adjusted it based on whether it was an emergency medicine intubation or an ICU intubation, whether it was trauma. They adjusted for a lot of different things, including using the standard definition of first pass success. So blade goes in, Bougie misses once, slight readjustment, passes. They would count that a first pass success. And they did a sensitivity analysis based on that also. Let's talk a little bit about inclusion and exclusion, because there's one part of this that I think is important. You can look at figure 1 in the paper, and this basically shows the number of patients that were recruited versus the number that were included in the study, and if they were excluded, why they were excluded. And I think this is one of the most important parts of any paper, this and Table 1. So their goal was to randomize 1,106 patients. They ended up with 1,102, spot on. You may be wondering how they came up with 1,106. Well, that was their power calculation. They wanted at least an 80% power to determine a 6% difference. Now, normally I don't talk about power calculations, but I like where they got the 6%, because that was the minimal clinically important difference. So if you have a difference in first pass success of more than 6%, they said that would be clinically meaningful, and they powered their study to detect it. So I like that. So they started off with 1,558 patients that were undergoing intubation that were potentially enrollable, and they excluded about 88 of them. 72, the majority, were because they used a hyperacute angle blade. A couple was because they weren't using sedation. And then they ended up with 1,477, and then they excluded a couple more. 14 patients were excluded because the intubating physician said this patient, something about them, requires the use of a Bougie. 4 patients were excluded because they said, nah, it's got to be a Stylet. Not really sure why. 11 prisoners, there's some other stuff in there, but that was the part that I thought was important. There were more than 3 times as many patients excluded because the physician said a Bougie was required. So they ended up randomizing 1,106 evenly between Bougie and non-Bougie. They did exclude a couple of patients after the fact because they realized that they were actually prisoners, and that wasn't known to them at the time. But that was even in both groups, 2 in both groups, so that couldn't impact the results. One thing that was interesting was of the patients randomized to Bougie, only 8 of them did not actually have a Bougie use on first attempt. But of the patients randomized to a Stylet, 15 of them, more, were intubated with a Bougie. So I think what this is telling us is the general gestalt among those physicians was that Bougie helps with more difficult intubations. And I think that's probably an important bias going in before we look at the results. And if the bias of the intubating physicians is that Bougie is the appropriate thing for more difficult patients, we would expect that to bias the results actually against Bougie, because these would be more difficult to intubate patients. That's the thought. All right, real quick look at Table 1. What were these patients? They were both about the same age, 58 years old. About 60% were men, not shocking. The majority either were intubated for altered mental status or respiratory distress. 63% of them, roughly a little over 60% in both groups, were intubated in the emergency department. The remainder were intubated in the ICU. Difficult airway patients, a little bit more actually in the Stylet group than the Bougie group, about 43% in both groups. Again, that's the power of randomization. It randomizes those difficult patients in both groups. In both groups, about 62%, 61 to 62% were residents doing the intubation. Fellows made up the remainder of that. Well, almost the remainder. About 2% in both groups had an attending do it. Pre-oxygenation, this really isn't a point of the paper. It's just a point that I like. About 50% in both groups were pre-oxygenated with a non-rebreather alone, which makes me sad. I think we know there are better ways to pre-oxygenate. A nasal cannula was used by itself in 30-ish% in both groups. That's not a very good way to pre-oxygenate. But the good news is that most of these patients, the saturation was pretty good. The median saturation going into the intubation was 100% in both groups. About 6% in both groups started the intubation with the patient still hypoxic. We don't like to see that. How were they intubated? Remember, the only thing that was randomized was the use of a Bougie or Stylet. The intubator got to pick the device they wanted to use as long as it wasn't hyperacute angled. About 23 to 25% of all of these intubations were done with DL, 75% were done with standard geometry blade VL, and the majority of those were a CMAC, a small minority were with a McGrath. All right, let's get down to what were the results. Was Bougie use associated with improved first pass success over standard malleable Stylet? That's what the authors were assuming. That was their hypothesis. That was what the prior literature was. That was certainly what I believed. So let's get to the main results, the things that you care most about, and that is going to be found in Table 3. Let's take a look at it. First pass success with the Bougie, 80.4%. Without the Bougie, 83.0%. That's disappointing. There was no difference statistically between those two things. Bottom line is that this paper does not show a benefit to the use of Bougie. Now, it also doesn't show a benefit to the use of no Bougie. There's just no difference, and that's very disappointing to me. How about how long it took to intubate? Well, it was longer statistically with the Bougie than without. The median duration of intubation, 124 seconds with the Bougie versus 112 without the Bougie. Probably doesn't matter. What matters about the duration of the intubation is whether there's peri-intubation hypoxia. No difference. It's 11 versus 8.8, statistically no difference in the amount of severe hypoxia. So that extra duration with the Bougie didn't matter. That was not the result that I was looking for. I really wanted to see a slam dunk showing improved first pass success with the Bougie. That's not what I saw. So because my bias is that the Bougie is helpful and should be used on every intubation, I really dug into this paper trying to find fault with it. And unfortunately for me, I couldn't. Turns out it's a really well done paper. So first off, it's randomized, and that's good. So all of the patients in both groups should be about even, and it looked like they were. Now, the first thing that I said to myself, and I said this to Dr. Abraham also, well, maybe it's because we're mixing intubators, we're mixing emergency physicians in medicine and pulmonary fellows. We're mixing intubations from the emergency department and the ICU. And it is true that first pass success in the ED was higher than it was in the ICU in both groups. But that's not what this paper is about. This paper is about whether Bougie use improved first pass success, and it did not. If you look at only ED intubations, no difference. ICU intubations only, no difference. Well, how about if it was trauma? Nope, didn't matter. Medicine? Nope, didn't matter. Well, how about if it was a really bad view of the chords? Maybe with a great grade view, it helped. Nope, didn't matter. Doesn't matter what your glottic opening view is. Well, what about patients with difficult airway characteristics? Maybe the Bougie is really helpful in those with a difficult airway. Turns out it didn't matter, no difference. How about the experience of the intubator? They looked at patients or providers with more than 60 intubations and those with less. No difference. The Bougie, it's not that the experienced intubators don't need the Bougie or that the inexperienced ones do. There's just no difference in Bougie versus Stylet. Same thing with use of the Bougie. So your experience using Bougie, they looked at that and they saw no difference. So bottom line here, what are my takeaways? Overall, I got to say this is a well done study. Even if I don't like the results, I have to acknowledge this is most likely to be real. It was a randomized control trial. It was open label, but I'm not sure exactly how you would blind the operator to whether they're going to use a Bougie or not. That would be a tough thing to do. So I think this is probably about as good as it's going to get. I would also tell you that the results of this trial will generalize to other contexts like this. So in other academic emergency and ICUs. Would it apply in the field? I don't know. We don't have that trial. I got to tell you, probably. But it definitely does not apply to my practice. Now, why do I say that? The reason is I don't use standard geometry blades. I only use hyperacute angled blades for all of my intubations. And therefore, this doesn't matter because they specifically excluded that population in this study. Now, first pass success in this study was lower across the board than other recent studies. And let's go through a quick look at what some of the first pass success rates that have been showing up in the literature lately have been. Remember, in this trial, we were looking at first pass success rates of between 80 and 83% overall. So Trent and his colleagues in 2021, this year, published a paper in Annals of Emergency Medicine using the NEAR registry to compare first pass success rates with video laryngoscopy and direct laryngoscopy in trauma only. And they found 90% first pass success with VL, 79 with DL. So looking at VL, 90%. That's higher than we saw with a predominantly VL group in this paper. Driver himself published a paper in Annals last year, 2020, looking at hyperacute angle blades versus standard geometry blades, VL only, again using the NEAR data set. He found 89% with hyperacute angled blades versus 92%. Both of those numbers higher than what we're seeing in this specific trial. Dr. Brown in Academic Emergency Medicine in 2020 did a paper looking at video laryngoscopy versus any type of DL with augmentation. So that's Bougie, that's ramped, that's external manipulation, any of those things. And they found first pass success rate with VL, again, around the 90% level. It was 91 there versus 81 with augmented direct laryngoscopy. Now, one big thing that all of those papers have in common is it's the NEAR registry, which means it is self-reported data. The intubator does the intubation and then writes down how many attempts it took. The definition is not as strict as it is here. One thing I will tell you is when they looked at the normal description or definition of first pass, and again, that is the blade goes in, the tube goes in successfully before the blade comes out, even if you have to move it around a little bit. Using that definition, again, the definition that NEAR has been using, 88% first pass success, much more in line with the existing literature. So bottom line, I think these results are real. As much as it disappoints me, I don't think there's a difference overall in first pass success between Bougie and non-Bougie. Now, again, I don't think this is a reason to throw the baby out with the bathwater. I think what we're seeing here is a difference in technique, not a difference in device. And I think this is fundamental, and it's fundamental to how we screw up the literature on intubation. We frequently ascribe to a device a difference in success. So hyperacute angle blades have a higher or lower success than standard, or this device has a higher success rate than that device, or bougie versus no bougie. However we're doing it, we think we are looking at something intrinsic to the device. In my opinion, it is almost always a difference in technique and how it's used. So my bottom line takeaway, great paper, doesn't apply to me because I don't use standard geometry, and I think it's about the technique, not about the device. So that's what I got for you. It's a great paper. I would welcome your comments. I'm really interested in hearing what y'all have to say about this. Do you think this applies to your practice? Do you see something in this paper that makes these results not apply to you? So let me hear what you have to say about it. You can get a hold of me at Dr. Jeff Jarvis on Twitter or jeff.jarvis@flightbridgeed.edu. Please give our podcast a great rating. I hope you like it. Tell your friends about it. And y'all have a great day. Oh, and by the way, it's December 18th. Merry Christmas. Happy holidays. I hope y'all have a wonderful holiday season. Stay safe. Keep the COVID bugs away and enjoy your family. Take care, guys.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.